Okay. Okay, hello everybody. We are starting now episode 8 of the iHub. And to remind you, the iHub is a series of scientific meetings arranged by the board of iCare Center in Alexandria in order to answer and to discuss common ophthalmic situations. Today's topic is about vernal keratoconjunctivitis, and we are honored today to have a distinguished, prestigious speakers with us. First, I would like to welcome Dr. Sihem Lazreg, who is our dear colleague from Algeria. She is the director of Cornea and Ocular Surface Center in Blida, Algeria, and she's an ambassador for the TFOS. And also Dr. Mahmoud Ismail will try to join us in shortly. He is, of course, the professor in Azhar University, Egypt. And lastly but not least, Dr. Tamer Massoud is an assistant professor in Alexandria University. And I'm very glad to have them with me at this meeting. And I hope that everybody who attends the meeting will come out with some important and useful tips and guides to the management of vernal keratoconjunctivitis. First, you have to know all that we all know that ocular allergy can occur in one of 5 forms: seasonal allergy, perennial allergy, vernal keratoconjunctivitis, atopic keratoconjunctivitis, and giant papillary conjunctivitis. Vernal and atopic keratoconjunctivitis are the most serious forms of allergy, of ocular allergy, because they can cause vision loss. Vision loss in VKC can occur due to steroid-induced glaucoma with glaucomatous optic atrophy. It can occur also because of severe limbal stem loss deficiency and corneal vascularization because of chronic inflammation and the use of multiple drugs. Also, it can VKC can cause keratoconus, or is tightly bound to keratoconus development. And also, the patient can lose vision because of shield ulcer with subsequent corneal opacity. Also, a lesser cause of visual loss is steroid-induced cataract. VKC is an important diagnostic issue in our ophthalmic profession, and it poses a lot of problems as it affects children, and children are known to be difficult to control their activities outdoor, and they are also difficult to comply with treatment. The disease also is chronic, and although it is self-limited in a lot of patients, but it is chronic, and it takes years to reach cure. Also, one of the problems, it is the control of activity, of disease activity, is difficult on the long term, and the parent's role is crucial. The ophthalmologist should explain thoroughly to the parents the disease process, the cause and chronicity of the disease, and also the treatment options and course. First, question, frequently asked questions by the patients. I would like to ask my dear panel about what is their opinion regarding the common question: does VKC end with the onset of puberty? How do you answer this question, Dr. Sihem, for your parents, for your patients' parents?
I can, in my experience, in more than 800 VKC in my data, VKC ends with the onset of puberty in 80% of cases. For the 20% of cases, it's not ends, but it go over another severe form, which is an AKC. The transformation is to AKC in the adult age.
Again, how much percent you say they end by puberty in the VKC?
80%.
80%.
Around 80%.
And you tell this to the patient, to the parents of the patient.
Yeah, I never promise to the parents that it will end, because I tell them, if you are lucky, you are in the 80% of cases which will cure at the age of the puberty, and if not, you can move to another severe form, which is the AKC, the atopic keratoconjunctivitis.
Dr. Tamer, what do you, does the age of onset of the disease affects this issue, the self-limit period?
No, not at all. Not at all. But what when you have, in the literature, you have two data. In the literature, VKC is a disease of boys. This is a masculine disease, and it ends at the age of the puberty. But in the real life, we have more than 40% of girls than female cases. Then the sex ratio is different in the real life. And in my experience, when the disease is in the female patients, it not end at the puberty.
In the female group.
In the female, yes.
So why does sex has a predilection, to males or females? Is it hormonal? Is it nobody answered this?
Nobody knows. This is this is in all. If you take any book, any paper, you will read VKC occurs in boys from 4 to 12 years old, but in the real life, it's not the case. We have in the French Society of Ophthalmology, every year we have a report. In 2015, we had a report on ocular surface, and I wrote the chapter of VKC, and I wrote this. I wrote that in the literature, the literature is wrong, because in the real life we have many female cases, and in the case of female cases, the disease is more severe, and it's not resolved at the age of puberty. But this is, this is a constatation. We don't know why. Maybe we have a hormonal factor, maybe.
Okay, thank you, Dr. Sihem. Dr. Tamer.
Yes.
Are you hearing me? Okay. Do you think the age? I've just asked the question to Dr. Sihem. Does the age of onset affects the end of the disease, or does it have a relation in your practice or in your opinion?
Actually, no, I don't think so. It doesn't have any relation to the end or when the disease ends. It only has a relation with the complications. The longer the duration of the disease, the more complications that we will have. So it's more expected to have keratoconus, cataract, or glaucoma in patients who develop the disease early. Actually, when parents ask me about when will this disease end, I tell puberty, and to make it easier for me, I say it most probably يعني in most cases it ends before the age of 20. I don't give them I don't give a specific time. So and I say that only few cases continue after the age of 20.
Okay. I think enough with this issue. We go ahead with the disease. When you come to, I won't speak about the diagnosis of VKC because it's easy to diagnose. It's not difficult. But the treatment is the issue, is the big issue. How to control the disease. Immunosuppressive therapy is the mainstay of treatment, but surgical intervention may be required to manage the disease and its complication. This is a sentence I read in a reference, and I like the idea that immunosuppression is the main treatment of this disease. There is no defined gold standard treatment algorithm for VKC, but there are many options available, and treatment should be tailored to each patient. Each patient should be managed in a specific or in a special way according to the disease severity. Treatment can be topical, is usually topical treatment, but we may resort to systemic treatment in some patients. Topical treatment, categories of treatment include vasoconstrictors, antihistaminics, mast cell stabilizer, and corticosteroids and immunosuppressive drugs. This slide I took from the American Academy of Ophthalmology, and they categorize the use of topical treatment according to the severity of the disease. If we have only micropapillae and no corneal changes, we can give mast cell stabilizer and antihistamines. If we have macropapillae and mucus accumulation with corneal vascularization, we give the patient topical steroids. And we have macropapillae with macro erosions and shield ulcer or persistent any other complications from steroids, we can give immunomodulating agents. These are the antihistamines and mast cell stabilizers available. It's a nice table. You can see vasoconstrictors as nafazoline and phenyramine, antivasoconstrictor antihistaminics. We use antihistaminics like levocabastine and imidastine. Mast cell stabilizers like sodium chromoglycate and lodoxamide, and these are all present in many eye drops in the market. And antihistamine mast cell stabilizers like alcaftadine, it's now available in Egypt. Azelastine, also bipotastine, epinastine, a lot of things, olopatadine, all of these are antihistaminic mast cell stabilizer combinations having dual action. They stabilize the mast cell release of histamine, and also they antagonize the H1 receptor. Also, corticosteroids, we have a lot of drugs. We have lotipretidone, I don't know how to spell this. Also, fluoromethalone, dexamethasone, prednisolone, all drugs are available. We will discuss together now. Dear panel, what about mast cell stabilizer and antihistamines? What are their role in the treatment of VKC in your practice? which patients do you prescribe to them these drugs?
Dr. Tamer, you want
ladies first? No, ladies first.
Okay. Then, can I summarize what you said now?
Okay, of course.
Yes. Then, for the treatment, maybe in the American school they don't have a standardized treatment, but in the European school, and VKC, if you say VKC, you say Italy. They are the most publication came from Italy or from Asia, not from America. Then they have their own protocol, and I am with the European protocol. Then first, if you need to treat VKC, we can't treat VKC without avoiding the allergen. This is an allergy. Don't forget that this is an allergy. If we say allergy, there is an allergen. If you don't avoid the allergen, you can give all the list you show, all the list, and we don't have any relief. Then first, we need to identify the allergen with the allergologist. Then to avoid it. The first treatment of VKC, and this is, I'm telling you what I'm telling to my patients. Patients, they are young and they're coming with their parents. The first thing that I explained, the disease, that this is chronic, not cure, and maybe it will be cured before the age of 20. This is true. But if you need that your kid will live normally, first he has to wear a hat. You have to avoid the UV light. This is the first enemy of VKC, the UV light. If you don't give the hat and the sunglasses, don't give any treatment. No treatment will work. Then this is the first. Then identify the allergen, the hat, and the sunglasses. And then I will start with the medical treatment. Then the medical treatment, the first treatment, we have 2 cases in VKC, or maybe 3 cases. First case, we have the VKC with only giant papillae without corneal involvement. If you have these cases without any corneal involvement, then we give an anti-allergic. The anti-allergic, we have antihistamine and mast cell stabilizers. We know in the classification, and if we go back to the classification, please remove the giant papillae conjunctivitis from the classification. They remove it. This is the new classification. Then you remove it. We have the atopic, the seasonal, perennial, vernal, and atopic. Then the vernal and atopic are both IgE and non-IgE mediated allergy. Then if you give only antihistamines, it doesn't work. Because in half of cases, we don't have histamine. We have only mast cells and not histamine, and we have a non-IgE mediated allergy. We have a T cell mediated allergy. Then in those cases, we give mast cell stabilizers. You will tell me in clinically how we make difference between this and this. We know that most of VKC are non-IgE mediated. Then don't give the antihistamine only if you have tearing, if you have itching, a lot of itching. Give them for 2 weeks. But the main treatment for VKC is mast cell stabilizers. And in our countries, in North Africa, from the end of February to the end of November, for the whole year. You give the mast cell stabilizers 3 times a day, 3 to 4 times a day. And if you have tearing or without corneal involvement, you can give mast cell stabilizers, or you can give the B action. You have B action like that. مش not ليفوكاباستين. ايه هم اللي عندكم البي اكشن؟ عندكم زاديتان؟
Olopatadine and Zaditan.
Olopatadine, yes, or Zaditan. Zaditan is B action. You can give it for 2 weeks and then you continue with the mast cell stabilizers. This is the first case when we don't have any corneal involvement. And if we have corneal involvement, we give steroids. Maybe you have another question for steroids?
Yes, of course, we'll speak about steroids.
Okay, then I will not speak about steroids.
You know, yani, I used to previously to use the mast cell stabilizers, Zaditan and olopatadine, but with time, their role in the management of the severe cases I usually face every day, I don't use them anymore, and most drug companies are not pleased with this. But actually they have a role, and I want to come back. I want to come out of this meeting by more confidence in these drugs, but when to use them, in mild cases
yes.
only, or in maintenance, how to use them?
This is this is a treatment for maintenance first. And I told you, if you don't use the sunglasses and the hat, you cannot ask the mast cell stabilizers to do all the treatment. This is not possible, because if the children are putting their mast cell stabilizers and looking to the sun and playing outdoor without any protection, of course it doesn't work. But if you have the protection, and if you give them all the year, it's because this is not a treatment for crisis, not at all. You know how it's the mast cell stabilizer, most of them, like I don't know, do you have the N-acetylglutamine aspartic, the NAGA? You have it?
No,
you don't have it. The NAGA, and also maybe chromoglycat.
Yes,
they are mast cell stabilizers, and they block the complement. Then they have two actions, two intrinsic actions. Then you have to be confident it works. And all my patients, I have really big data in VKC. All my patients start their mast cell stabilizers in the end of February, and I stop in the end of October or November, depend of the weather.
So you start.
It's not a treatment for a crisis.
Before the attack comes, you start.
Oh yes, this is a preventive treatment for prevention. Then you need to start them very early.
That's smart. Okay. Okay. Let's come back to the presentation. Then after mast stabilizers, the topical steroids. It's a big dilemma, of course. Topical steroids. The topical steroids are important. And they are the savior of the condition when the attack begins. You give the patient usually a pulse therapy or pulse regimen for steroids for a certain period of time, 10 or 14 days, and then you continue with the mast cell stabilizers or the antihistamines combination. But I want to know every one of you, how do you use steroids? Which steroids, and for how long? And what do you tell the patient about the side effects, and how do they control their regimen? So can Dr. Tamer tell us what does he do?
Well, actually, I would like to start with the previous question.
Okay.
First of all, the hallmark of VKC to the patients is itching. The patient comes with his parents complaining of him severely rubbing his eyes. Their main concern is how to stop this rubbing and how to relieve the itching that he's feeling. Also, how to relieve the chronic redness of his eye. First of all, as Dr. Sihem said, I usually tell them that this is an allergy, and it is due to something in the surrounding environment. Actually, I'm not treating the disease. I'm treating the symptomatology of the disease. I'm treating the symptomatology of the disease. So I'm trying to control the condition, but the cause of the condition is still all around you. In order to fully treat it, you have to avoid the cause or the allergen, as Dr. Sihem said. And if it is unavoidable, then please help me control the condition by doing some modifications of the environment surrounding your child. I usually advise them to let the child wear glasses with proper ultraviolet protection, wear hats, warm or hot environments. Usually, I tell them if you have an AC, keep him in the AC all the time. We usually see that these cases get worse during hot seasons of the year, and they get better at the cold seasons. I tell them keep them in as much as cold environment as you can. Also, I want also to emphasize on the role of lubricants in such cases. These patients usually have dry eyes, and this requires proper lubrication. Lubricants also, if they are of low viscosity, they can be used frequently to wash out the inflammatory mediators released in the conjunctival sac, also to dilute the allergens or the allergy-causing substances on the ocular surface. This is very important.
Yes.
As for treatment, I usually try to classify my patients into mild, moderate, and severe. Mild cases usually respond to histaminics and mast cell stabilizers without the need of using steroids. However, in acute conditions and in order to satisfy the patients to bring the patient satisfy the parents and to bring the patients into rapid relief of symptoms, I usually start with steroids. My first line of choice in such cases is to use low potency steroids, fluorometholone and ramixolone, to start with. I don't like using the potent steroids like prednisolone phosphate or dexamethasone because of their long-term complications. Yes, the patient or the parents say that whenever their child uses such drugs, they marvelously improve. However, this is a temptation to the patient, to them, to keep on using this drug without telling me, and this what puts the patient's eye into risk. So I usually start with using the low potency steroids, and according to the response, I either keep it or change to a more potent steroids. I also use steroids in pulse therapy, starting with 4 times daily and reducing gradually according to the response, together with the other antihistamine cell stabilizers, so as to keep the patient on such treatment for a longer duration.
So you start with a low potency steroid and then you taper it.
Yes.
For how long? Usually for how many days?
I usually do not exceed 2 weeks, but some cases might require the continuation of such steroid therapy for about 4 weeks.
And then you continue with the mast cell stabilizers.
That I start with the steroids. I start them together and I continue after stopping the steroids.
And when do you get the recurrence? The recurrence, don't you face recurrences with mast cell stabilizers?
Sure. Sure, I faced the recurrences many times. When do I get upon the compliance of the patient and his parents as regards the other environmental modifications that I ask them to do? If the child is compliant, I usually do not get a recurrence early. But if he's not, once we stop steroids, the recurrence is imminent.
Okay, so the tip or the advice for the audience now that you start with low potency steroids, topical steroids, even if a severe form, Or
No, not in severe form. Not
severe
in
forms, you
severe
stop
forms. I use the high potency steroids first, as a
first.
يعني, first, yes.
And do you monitor the IOP مثلا in 2 weeks or something, or
Sure.
you don't?
Sure.
Sure. Okay. Dr. Sihem, now we will speak about injection of steroids. Do you inject steroids, and how do you do that?
Yes. Can I just talk? I agree with you, Dr. Tamer, only if one point. Even maybe you are not seeing the same VKC than me. Then the low potential steroids doesn't work at all in VKC when they are in acute phase. Never. Then
Even my
yeah, I'm using dexamethasone. Dexamethasone with the pulse doses. Then and 4 times a day, it's not enough. I'm giving 6, 8 to 10 drops a day for 6 days to 10 days, and I never exceed 10 days. And with these doses at the third day, they are very, very nice. But I'm seeing the patient at day 0 and at day 10. And I tell to the parents that this is a potentially blinding treatment. They can be blind with this treatment, just to scare them. And they must stop. I must see them at the end of the steroids, just to stop by myself the treatment. And as you, I'm starting the mast cell stabilizers with the steroids, because if I give, if you give fluorometalone or another steroids, they will not feel better, and they will see another doctor. He will give steroids, and the third doctor will give steroids, and these are the cases will end with glaucoma related glaucoma or cataract. I have many of them. I never, every day when I have surgery, cataract surgery, I have at least one cataract in VKC, at least one.
Wow.
Every program.
It seems that the disease incidence is very high where you see your patients.
Aggressive.
No, because they come because I'm a specialist. But I think that in Egypt we have the same climate as in Algeria. We have severe cases. Then we need to stop with the very high doses for a short time. We need to be strong with and never go slowly. You stop. You give maybe 8 times a day, and you stop at 8 times. You don't decrease the doses. This is very bad in ocular surface in general, in all ocular surface diseases. You stop suddenly your treatment, and we continue the mast cell stabilizers. I don't agree with you, Dr. Alaa, with the vasoconstrictors. They are very, very bad, very bad. And we have very big side effects in children with that. I never give them. We don't have them in Algeria. Anyway, we don't.
They are not vasoconstrictors. I didn't say. I say mast cell stabilizers and antihistamines.
Then you don't give vasoconstrictors. Then just for people to understand that we don't have to give them.
So your regimen is to give
dexamethasone, high dose. For if I have a corneal involvement, if I have punctate keratitis, an ulcer, if I don't have participation of the cornea, I don't give steroids. I only give I explain to the patient for the head, the sunglasses, and to avoid allergens, and mast cell stabilizers. And you are right for the lubricants. This is very important to give lubricants in these patients. And that's it. And if I have a corneal participation, even it's a small punctate keratitis, in this case, I give steroids. Then, when I have frequent relapses, what we call frequent relapses, if my patients have one acute crisis per month, I consider it that is a severe case, and this is a frequent relapse. 1 per month, it's not permitted. Then I move to the injection, to the supratarsal injection of triamcinolone. Then yes.
Do you give it in the clinic or in the OR, or according to the age of the patient, or what?
Whatever the age, I give it in my clinic. Not under anesthesia. Not under.
And
whatever the age.
A 6 years old girl
even
can.
2 years, 3 years old, whatever.
It is painful. How do you do that?
Yes. No, I give you my my tip. You take the ampoule of triamcinolone, and you put 1 cc of xylocaine.
Yes.
And you, when you have this mix, you mix it with xylocaine, and you give half in the upper lid, both upper eyelids, half and half. And never in. I give it in my clinic. I give 3, 4, 5 per day, every day.
Every day supratarsal injections.
Yes.
But I have a different tip. I do another thing.
Yes.
Tell me. I insert a small piece of cotton soaked with inoxidant under the lid, under the upper eyelid, and leave it for a few minutes, and then I give the injection. But the problem is that most people in our country, when they see the needle approaching their
in our country also.
How do you do that? What effect do you have on patients?
The problem is not the patient. The problem is the parents of the patient. Then I can, I talk to them. You have 2 choices. I can give a general anesthesia with all the risk of anesthesia, or I can do it now. He will have small pain, and that's it. This is 3 seconds. We inject in 3 seconds. And when the child is very young, what is my tip? I put it in in un drap. Comment on dit un drap en français?
Indral?
L'indrat tabi.
ملاية. Cover, yeah. ملاية.
I cover. Yes, I cover the child. I cover it, and in French we tell it langeage. Then I close. I maintain his hands and his legs with the cover. And my assistant take him, and I give the injection. This is only 2 seconds.
So you restrain the patient. You tie his legs and arms, and oh my God!
Yes.
When did you learn that?
In the hospital. I was in the hospital, in the university hospital, and we were doing this like this. And even in France, they are doing this without anesthesia.
So let me ask about the follow-up of these patients with supratarsal. What do you do?
This is important. Then I give the injection, and I see the patient 1 week after.
1 week.
At day 7. Yes, after 1 week. And don't forget to give him also the mast cell stabilizers. Even you give the injection. The mast cell stabilizers, you should give them all the year. Then I give the injection, and I see him at day 7, just to see if I don't have any complication. But seriously, I'm giving this injection maybe since 10 years. I never had any complication. Never.
from my own experience, I used supratarsal injections for years and years, and actually, my dear colleague and friend, Dr. Ahmed Chema, was the first one to introduce me to this kind of treatment of VKC, and I appreciate very much his tips. But I used to repeat also supratarsal injections many times, twice or thrice.
Me too.
And until I got
every year, one per year.
Until I got a patient with increased intraocular pressure, and it didn't come down. It didn't go down, and it was 30 millimeter mercury with 3 types of drugs, and I was miserable.
With one injection? Only one injection?
No, 3 injections. I injected 3 times.
But what were the time between the injections?
Months, 3 or 4 months apart.
It's this, before, don't re-inject before 6 months.
Is this
I never re-inject before 6 months, never.
This is a good advice. Maybe because to allow enough time to elapse between, to avoid the accumulating steroid-induced increased intraocular pressure.
Yes, I never re-inject before 6 months. If I have another crisis before 6 months, then for me it's not working. I never inject again, and I move to another treatment, cyclosporin or tacrolimus.
Okay.
I don't re-inject again.
Doctor,
because you are supposed, with the injection, the patient is supposed to be calm for at least 6 months.
6 months with one injection of triamcinolone?
Yes.
Maybe with the other measures, with the other...
Yes. This is, the other measures I don't discuss about this. We should, when I see my patient the first time, I am telling to his parents, next time, if you come back without the glasses and without the hat, I will not receive you. I shock my patients. I not see the patient. If he come to my clinic without the hat and the glasses, I don't see him. Even he comes from 800 kilometers.
You reject him.
Yes. Because this is very important. This is most important than the treatment itself.
Very nice. Dr. Tamer, I know you are a very conservative person, or a very conservative doctor, not person, and you don't like the misuse of steroids, even infections and things. Injection of steroids, do you do that? Or you don't like it, or you don't do it at all?
I do it, but I don't like it.
Yes. You fear it.
I do it, forced. I'm forced to do it. And I do not.
In which cases?
In cases that have giant papillae starting to have corneal involvement. The use of topical medications will be of no use for them. So I usually resort to supratarsal injections, and I take care not to repeat the injections because I know that they can continue for 5 to 6 months.
It's magical. Everybody experiences it. You inject in
2 weeks, and the patient is very satisfied.
In 2 days. In 2 days.
No, I mean about the lid edema and the papillae. The lid edema and the papillae, they reduce in size within 2 weeks.
And the parents are so grateful to you. You have done a miracle, doctor. But of course, you are responsible for this miracle. You can have the bad side of the miracle. So we advise
I totally agree with you.
To measure intraocular pressure and to follow it every 2 weeks or something. We have a lot of questions here in the comments. Do you see them with me?
No.
a lot of questions. Dr. Ahmed Shama is welcoming Dr. Sihem and Dr. Tamer. And
thank you.
we have a message from Sharif Ikram. He says, I always tell my patients regarding allergy in general and VKC in particular, it is an incurable disease by 100%. It all comes down to their nature and environmental factors. Thus, the main goal is to minimize the symptoms and any complications that might happen later in life. It should be explained to them it is different from bacteria and virus to keep it simple for them.
Oh, yes.
Okay, it's nice. It's a good advice. And
excuse me, you know, the first consultation of VKC is very long. You know, it needs more than 30 minutes because you need to explain to the parents that is chronic, that is mostly incurable. Then we have complication, and the most complications are due to the treatment, not to the disease. And all what I said for the head, and the first enemy. I tell to all my VKC, your first enemy, your big enemy is the UV light. Then avoid the UV light, and you need to go to allergologist to know what is the origin of this allergy. It takes it's time consuming to see VKC for the first time at least.
This is the major advice from this meeting, that all doctors who receive a patient in their clinic for the first time with VKC, they have to spend enough time explaining the disease process and the treatment process, because this is crucial, because we all face patients coming to say the same silly statement. We took treatment and it didn't work.
Yes. Yes.
The doctor didn't explain the magnitude of the disease or the problem.
This is the difference. The difference between the difference is not the treatment is not different, but the doctor should be different. The doctor should explain to the patient that they don't stop the mast cell stabilizer, whatever. I don't know. You have preservative-free mast cell stabilizers?
Yes, it's coming.
You have them?
Yeah.
This is great, because for a long time you can't use also preservative for a long time. This is not good for allergy and for ocular surface. Then we need a lot of time. If you don't want to spend time with your patient, don't be ocular surface specialist. Go and do refractive surgery.
We do both. صاحب بالين كذاب. From Dr. Sharif Ikram and Muhammad Sayyid, they are saying that they oppose your idea, Dr. Sihem, about not using sedation and general anesthesia with children. They say,
I know. My Egyptian colleagues are against me for this, I know.
Muhammad Sayyid بيسأل, what about mix between Kinacort and dexamethasone? Do you use it for injection?
Why?
Maybe
no need. Kinacort is enough. We need. Yes, for the long acting. This is the same molecule.
Wanes after a period of 1 or 2 weeks maximally.
No, after hours. Dexamethasone is very, the half-life. The half-life is very short of dexamethasone. We use the Kinacort because the half-life is long. This is why we are using. Why supratarsal? Because we use a TARS like a reservoir. We inject into the TARS, and you use the TARS as a reservoir of steroids.
Dr. Ahmed Shama is asking about non-steroidal anti-inflammatory drugs. Do you use them?
I don't like them.
He's mentioning Ocular eye drops in specific.
Yeah. I don't like them. Yes, you know, you can have a relief because they have the problem of the non-steroidal anti-inflammatory, that they have an you know intrinsic anesthetic effect. Then, if you put them in the eye, you have some relief, but it's a false sensation. This is anesthesia, and it's not good because we need the pain to know if we have a corneal involvement first. And second, all the NSAIDs, all are epitheliotoxic.
Toxic,
then
yeah.
You have a very fragile epithelium, and you give and you put on it a toxic drugs. No, I really am against the NSAIDs in allergy. Maybe for a short time, for 3 or 4 days, to have some relief, but not more.
I have a question from a doctor saying, can you show us the technique of supratarsal injection?
How? Dr. Alaa?
I don't have the movie now, but...
no, yes. Maybe next time I will give you, I will record and give you the movie. This is very easy, you know. You reverse the eyelid, and you give it in the interface, and you go perpendicular to the TARS. And this is not easy. At the you should feel the TARS. It's not how my English is very bad. The TARS is not like the conjunctiva, or this is hard to enter in it. And you go perpendicular and you inject. Frankly, you inject very fast. Don't go slowly. You inject the half of the injection
in the tarsus itself.
In the tarsus, yes.
I don't do that. We are different.
Maybe yes. This is the aim of this. Yes, I go into the TARS.
That's is this the usual in the European way, or the?
I don't know. You know, there's no paper on that. This is the supratarsal injection or the intratarsal injection is not. Everybody has his own recipe.
You are saying intratarsal injection, not supratarsal.
Intratarsal.
You inject in the fold of conjunctiva. When you evert the eyelid, the upper eyelid, you have a fold. So I inject parallel to the upper tarsal margin. I'm sorry, doctor.
This is why, you know, this is why you have relapses before 6 months.
Because we don't.
You have a resorption. You have a quick resorption of the canal cord. If you use it into the TARS, I told you that the TARS will be a reservoir of steroids. It's, you know, you have something like it's strong. It's not mucus. It's then you go into and you inject. I will give you a video next time, maybe.
Yes, this is interesting. This is interesting, actually.
Yes.
And we have also some questions. What about cyclosporin and tacrolimus? We are going to speak about this shortly. Actually, after supratarsal, we have the topical immunosuppressive drugs, cyclosporin A and tacrolimus. Actually, I started using cyclosporin A few years ago, and in a concentration between 0.05% and 2%. And I didn't continue actually to use it because of the severe burning sensation the patient feels. So what is your experience, Dr. Tamer, with cyclosporin A? What do you advise people to do with cyclosporin A?
I actually have the same experience as you do. I started using it, and then because of the severe irritation and the severe burning and stinging sensation that the patient feels, I didn't have that much of a compliance, especially with higher concentrations of cyclosporin. So either I use the commercially available 0.05%, which I think is not that effective, or I resort to tacrolimus.
Mhm. You know, I have major ambitions in cyclosporin A because, of course, it can be used in corneal grafting to avoid steroid-induced glaucoma. But I didn't even know how to use it in grafting, in keratoplasty. So you don't use it in any way, in allergy or in dry eye or
In dry eye, I use it. In dry eye, it's FDA approved for dry eye, the 0.05% concentration.
Hmm.
And I think 0.1% is approved in the European.
iCare.
Yes.
Uh-huh. So cyclosporin A is prepared in castor oil or olive oil or corn oil, and they have to be prepared in the pharmacy and used 4 times daily. A
The
lot
only
of
country that approves the use of cyclosporin A for the treatment of VKC is Japan. Otherwise,
No.
it's
No,
an
no, no.
off-label treatment, I think.
No.
only Japan.
No.
Yeah.
No, it's in Europe. It's available in Europe, and we have a clinic. We have now. We have
Is it
finished a
approved
new.
or still an off-label treatment?
No, it's approved.
Okay.
But for
Mm.
the can I just one word for the cyclosporin?
Yes.
Cyclosporin, the 0.05 is not it's not working for VKC. The only 1% and 2% are effective in VKC, and it's not what we need to tell in this topic, that this is not for the crisis. This is not for the acute stage. The cyclosporin is not a treatment for the acute. You can't not replace the steroids by the cyclosporin. Not at all. It's not the same action. This is a chronic treatment. When you start in VKC, if you start cyclosporin, you start it for 6 months at least. And now we will have in Europe. We just finished the clinical trial with Santen with the dedicated cyclosporin to VKC, which name is Vercasia. It will be available in the market next year.
What percent is it?
It's the same. No, it's the same as iCare, but it's in 0.1, but it's soluble in a cationic solution. Then they use the cationic solution to vehicle the drug, the cyclosporin.
Okay, nice.
But it's not. Forget it for acute stage. It's not working. Even in the clinical trial, we use for the acute stage association with the steroids and cyclosporin. Then we stop the steroids and we continue with the cyclosporin.
But it has a very potent effect in maintaining and controlling or preventing recurrence of disease than muscle stabilizers. It is very successful in this. And also
this is very successful, but you should not give it. It's not useful for every VKC. You know, here we are talking about severe VKC with corneal involvement and with frequent relapses and with steroid. How we say it? Dependence.
Responsiveness.
We have. Dependent. We have patients who are totally dependent to steroids. when you stop the steroids, they are in the recurrence. We have recurrence. Then these are the indications of cyclosporine, but not for acute stage, never.
Yes. And what about tacrolimus? Tacrolimus, I've been using tacrolimus for over a year now in VKC. And just before I meet you today, I have a patient who is 6 years old, and he's been using tacrolimus for 14 months now continuously, and the mother is very satisfied with the treatment. But she told me, for how long will I continue using this drug? Is there an end for this? I didn't know.
You use it ointment or eye drops?
Eye drops, twice daily, 0.03%.
This is magic. For me, the magical thing in the magical drug in VKC, this is tacrolimus.
Yes, it's a big discovery, actually.
Oh, yes. I use it, but I don't have the eye drops. I have the ointment, but it's off-label. You know, that we are using it off-label once a day because it's burning once a day for 2 or 3 months. I never exceed, for the moment, I never exceed 3 months. And the indication is the non-responders to the intratarsal injection. When I have relapses before 6 months, I know that it's no responder. Then I move to the tacrolimus.
And how long? How do you use it? Yani, do you stop it at one time, or you don't?
I never exceed. You have in the literature we have 2 or 3 papers with severe side effects with lymphoma. Then be careful with this drug. It can induce lymphoma.
In the topical treatment?
Yes.
Lymphoma?
You have a systemic only if you put plugs, but if you don't put plugs, punctal plugs, you have systemic passage of tacrolimus of the.
Wow. Lymphoma is a great problem, side effect. So
yes, be careful with that.
So, what about Dr. Tamer? Do you use tacrolimus in VKC and dry eye?
Yes, I use tacrolimus 0.03% eye drops. I started using it the same time you started.
Yes, I remember this.
Yes, and it's a magical drug. And I've seen cases that were resistant to treatment that responded properly. They responded marvelously to the treatment.
But for the audience, how do they in Egypt? How do you get it? How do you get 0.03% eye drops? Do you
the same way you get it? We made an agreement with a pharmacist who prepares the drug for both of us.
Yes. So you ask the doctors to send a specific pharmacy. I think many pharmacies in Alexandria and in Cairo and all over Egypt, they can prepare it. It's not difficult. It's not difficult like cyclosporin A. Cyclosporin A is really difficult to prepare, but tacrolimus is not. So it can be used. It can be prepared and used safely, and it is not also stinging or burning like the cyclosporin A. It is a little bit burning, but for a few days, and then it goes away rapidly. And the patient, even children, tolerate it.
Only the first few days.
Yes. But lymphoma,
you have the dilution with what? You make the dilution with lubricants? You don't know?
I can't know.
Or with saline?
I think it's water for injection or artificial tears. It's nothing specific. Nothing specific like cyclosporin A.
Okay.
I have some papers about reviewing of literature. This is a long-term safety and efficacy of topical cyclosporin in 156 children with vernal keratoconjunctivitis. I think it's in Italy also.
Italy, Leonardi, he's the master of VKC, Andrea Leonardi. He did the new classification also.
of VKC.
No, of allergy, of ocular allergy.
In all. In this study, a large population, 156 children, was followed for a mean period of 3.8 years. They all underwent cyclosporin A eye drops treatment for a mean of period of 6.4 months every year. The serum cyclosporin A levels were measured once a year, and the blood pressure was determined twice a year. They found out that the drug is almost in all children, it is safe and effective treatment for VKC. Also, this is another study comparing a randomized placebo-controlled clinical trial for tacrolimus ophthalmic suspension, 0.1% in severe allergic conjunctivitis.
This is Japanese, no? This is not a Japanese?
This is Japanese, yeah.
Because in Japan, tacrolimus is available in the market, in the eye drop. It's available. The 0.1% is available in the market.
Higher concentration also. And 56 patients with severe allergic conjunctivitis in whom topical anti-allergic agents and corticosteroids has been ineffective were randomized to tacrolimus or placebo treatment. And patients were treated either with tacrolimus for 4 weeks. Tacrolimus was effective in treating severe. Also, most papers say this, that it is efficacy of topical application of 0. A lot of papers acknowledging what we have experienced in our practice. Here is another paper comparing tacrolimus and cyclosporin A in severe cyclosporin-resistant vernal keratoconjunctivitis. They found that significant improvement in objective and subjective scores was observed in the eyes treated with 0.1% tacrolimus. The quality of life significantly improved despite only half the eyes being successfully treated. Yani they improved symptoms, even they are not clinically improved. So what about the surgical management of VKC? Some doctors still use cryoablation of the giant papillae, or they remove the giant papillae surgically. Do you approve this, or do you did you do anything like this before? Tamer or Sihem?
I did it maybe 15 years ago, but I never do it again. And now it's contraindicated in the management of VKC. Don't touch to the giant papillae. You know why? Because you can get the disease worse if you touch. The giant papillae have not any mechanical effects on the cornea. This is a wrong knowledge. They are full of eosinophils, and all of us know the eosinophils have in the cytoplasm many cytotoxic substance. Then, if you remove them, if you touch them, you will release all the eosinophils and all the toxic material of the cells, and this is really a danger for the ocular surface.
Some doctors still do it. Yeah, that's few. I know there are few, but they resort to this cryoablation or surgical removal. And one of the messages I'd like to convey from this meeting is that this should be abandoned. This is very bad, and it leads to a lot of fibrosis and fornix obliteration and dry eye, and a lot of problems may happen because of this.
You destroy the ocular surface by this way. You destroy it completely.
Yes. But the debridement of the shield ulcer plaque is a useful aid for the treatment of shield ulcer.
Of course, not useful. It's mandatory. You need to remove it. We can't have any healing of the cornea if you don't remove the plaque.
You're right, but usually I wait a little. I inject supratarsal and then I wait for a few weeks. If it doesn't go away and the eye is quiet, I debride the shield ulcer, the plaque.
If you have a general anesthesia if you give a general anesthesia to give the injection, remove the plaque, by the way, in the same time.
You're right. So
I do it. My Egyptian colleague will be angry. I remove the corneal plaque at the slit lamp.
So, Dr. Sihem, you've spoken to me about allergology, and that you are having a connection with an allergy specialist who can do for you a desensitization of the patient for the common allergens in the environment of the patient. Is this, can you tell us how can we do that in Egypt, or how can we, because most of us don't do that. We just avoid the allergen and treat the symptoms and the signs. But to desensitize the patient from this allergen, how can we do that? How can we do that in your opinion?
Okay. That, in my opinion, I think Dr. Tamer will agree with me, because he spoke also about the allergen and the identification of the allergen. If you don't treat the allergy, you are treating only symptoms, not the disease. The disease is allergy.
The cause.
The cause, we need to identify the cause of this allergy. And if the problem in VKC, when we have incisional or perennial allergy, this is very easy. 100% of cases you find are IgE mediated. If you say IgE mediated, then you have an allergen. The problem in VKC that you have a double mechanism. This is IgE and non-IgE mediated. Then in 60% of cases, we have a positive test. The skin prick tests are very, very, very easy. In Algeria, we have hundreds of doctors, specialists in allergy. You can, and I can't work, I can't do my consultation if I don't have an allergologist with me. This is very important to treat my patients. Then the allergologist, I can show you, if you want, how to do the skin prick test. Can you share my slides?
Okay. I will stop screen. You can share now.
Are you seeing my slides?
Yes.
We were seeing them, yes.
They are gone now.
But
yes, now.
But I'm not seeing.
Shadi, help us.
Can you help me, please?
يا دكتور حضرتك بس اختاري الباوربوينت من تحت واعملي لها فول سكرين.
Okay. Like this.
ايوه.
فول سكرين بقى.
Okay.
دكتور علاء حضرتك لازم تشير السكرين بتاعت حضرتك برضو از ويل.
انا اعمل شير انا كمان؟
خليها بس موجوده في الشيرنج.
طيب اوكي.
Like this you are seeing. Then the skin prick test, you see like this. You put a drop of the allergen. You have boxes, and you can buy the box with the common allergens. You put on the skin like this, and you give a scar, a prick, and you wait for the reaction, small prick, like this. And we have in the box we have something like 12 allergens, the common allergens, and you wait for the reaction. And in ophthalmology, you can do the conjunctival provocation, the test in conjunctiva, like you see in this. You put the allergen on into the eye. This is a drop with the higher concentrations and with different dilutions, and you wait for the reaction like this after 30 minutes, after 15 minutes, and after 13 minutes, like this.
Is this increased hyperemia or edema? Or what is the
yes,
effect?
It increased the hyperemia, the edema, and also the itching. All the signs you are provoking an allergy, ocular allergy.
You mean we can do the skin prick test and do it in the conjunctiva also?
Yes, you have the skin prick test and you have the conjunctival test, both of them. But you have to start with the skin prick test to identify. If you have only one allergen, it's easy. But in most of time, you find maybe 6 positive reactions, and only one of them is reacting in the eye. Then you choose the most important, and you do the conjunctival provocation. It's not, the basis is to do the skin prick test. This is very easy. You can go in internet and go to Stallergen. This is the company. And you can order the box with this is very easy. And if you have a general doctor with you or an assistant, he can do it for you. And by this way, you can identify the allergen. When you identify the allergen, first, you can avoid it. And second, you can do this desensitization. The desensitization, we have two, I will show you. We have sublingual and the injection, intradermic injection, by two ways. And now all my patients, when I identify the allergen, I do the desensitization. And you decrease the disease by 10. They are very, very nice. You don't use steroids. You don't use any cyclosporin. You need to treat the cause, the etiology of the allergy.
How do
you are treating?
The doctor, the allergologist, inject some antibodies? What do they do?
This desensitization takes 3 years. 3 years. First, for the first 3 months, you inject every week, and then every month, and then every 3 months. You inject small doses of allergen, and you increase the dilutions. Like this is desensitization.
Is it successful?
And now, oh yes, I did it myself because I have allergy. I did the desensitization when I was young. I did it for myself, and this is really very useful to treat allergy. And now you don't need to use needles. We have a sublingual one. The same. This is drops that you put under the sublingual every day.
Tongue.
Yeah, and this is very, very effective.
Actually, I'm interested in this, and maybe you will help us.
Yes, reach, in Algeria we have a diploma on this. We have a certificate in allergology. It takes one year, but you have one course per week for 8 months, and we have a certificate. You can give this formation in the university. This is a certificate. And every doctor, the dermatologist need that, the pneumologist need that, the ORL, Alf Hogara, all these specialties needs allergologists. how they are treating their rhinitis, the asthma. How do you treat this without allergologists? We can't treat.
Very nice. We actually I didn't find the right way to do it. You know, it's very logical, but the right way or the means of get my hands on this.
You know, we can with the university. We can learn to doctors how to learn allergy. You know, this is a diploma.
Okay, we
less
have
than 1 year.
Dr. Sihem,
I can give you the program from here. I can give you the program of the courses. And we have also in Algeria, we have an Algerian Academy of Allergology, and we are many specialties. And in France, we have the group Ophthalmo-Allergology. This is a big group, and we have our meeting with the French Society, a small society of Ophthalmo-Allergology, and we are working with our colleagues allergologists. This is a specialty.
Me and Dr. Tamer will encourage some of the young doctors to go on into this subspecialty, be an ocular allergologists. It would be a new
or allergologists. Only you know, we have this is a specialty. You have medical doctor, and he can have a specialty in ocular in allergy. Then he can have his own proper clinic. He can do for you all the skin prick tests and treat all the allergies. You know, the skin allergies, the all the respiratory allergies. This is a field. I don't know how you don't have it.
We all manage allergy, but
yes, I see.
Specialty.
This is nice, but you can't. You know, this is too difficult to manage them.
Yes.
You can manage the eye, but you can't you know, when you have VKC, just ask them. The first question I ask to the parents, comorbidities. And in maybe more than half of cases, you have a comorbidity. You have asthma, rhinitis, you have eczema, urticaria. You have all this, you have association with another allergic disease. And how do you manage it? You can't not manage only the eye. You need to manage all the disease.
You're right. We've been now discussing for more than an hour and more, about 75 minutes now. We've been discussing, and we want to conclude what we have said in simple points and tips to the audience. I think we've spoke first at the about the environmental factors and how to contain them, and the cap and the glasses, sunglasses, and also we've spoken about the mast cell stabilizers and steroid injections and shield ulcers. We've spoken about the tacrolimus and cyclosporin A. I think we've covered most issues about the management of VKC. Is there anything else we didn't speak about, in your opinion?
Yes.
What?
Keratoconus associated to VKC.
But this is a big issue.
No, only one take-home message. Do a pentacam for all your VKC, and you will be surprised. Only one word.
That's good. That's a very nice tip. But some time of VKC, after having VKC for a few years or first presentation, I should do it.
I do it maybe not a first presentation when he's in a calm period. When I'm in a calm period, maybe after 1 or 2 months, and you will be surprised. You have really very, you know, I have data of more than 800 cases. The data that I with statistics, I have 21.2 of keratoconus.
That's right. That's true.
And
Wow.
88% of astigmatism. All of them are astigmat.
That's true. That's true. I usually do an autoref and glasses. I do prescription for them when they are quiet.
Just try to do a pentacam, and you will be really surprised.
I usually do retinoscopy and scan for the scissoring reflex. I look for the scissoring reflex rather than asking for pentacam.
That's simple.
And I usually am, yeah. And they have a very high incidence of scissoring.
Yes.
Okay.
And then maybe if you permit me to, don't forget also the psychological impact of this disease, please.
Sure.
Yes.
It's our kids,
especially on
and
the
they are
parents.
really suffering. They are suffering.
This is a final slide for my personal approach to VKC. I hope I didn't forget anything. But first, I counsel the parents regarding the disease and treatment course. At the first visit, I speak with them for some time. And then I give the patient with severe form, or they usually come in a severe form and not in the mild treatment. I give a pulse therapy with topical steroids. I like dexamethasone phosphate, like you do, Dr. Sihem, followed by a topical combined mast cell stabilizer. I don't follow it. Actually, I start with the dexamethasone, and then I stop it after about 2 weeks, the dexamethasone, and then I continue with the combination of mast cell stabilizer and antihistamine. And in severe cases with VKC...
Excuse me, just one. If you permit, just start with both of them, because the mast cell stabilizers take 2 weeks to start working. Then when you give the steroids, you give them the time to start to work in the eye.
You're right. I didn't. The word followed is wrong. I start both of them together. And severe VKC with giant papillae, I give supratarsal injection of combined short-acting and long-acting steroids. The drug I used to use was called DEWSII, and it contains 2 types of steroids, a short-acting and a long-acting. And then I monitor, of course, the clinical response and intraocular pressure changes. And in steroid responders, I give topical cyclosporin A 1 to 2%, if in olive oil 4 times daily, or topical tacrolimus 0.3% 2 times daily. And I usually give also with this a mast cell stabilizer also with the topical tacrolimus. Sometimes I don't use it, sometimes I use it according to the effect of the tacrolimus. Do you have any modification in you about this?
No, it's perfect.
Perfect. Dr. Tamer?
Maybe I can add that treating other allergies in the body can help improve the eye condition.
Allergies in atopic patients, you mean? Bronchial asthma or
rhinitis, sinusitis,
and treating them will help
relieve the eye condition and and reduce the amount of eye drops that I'm using.
Okay. I think we have said everything about the management of vernal keratoconjunctivitis, and I hope our messages are delivered. I was very delighted actually to have Dr. Sihem and Dr. Tamer with me today. I hope we can meet in the future again, and the near future, inshallah. And thank you very much, Dr. Sihem, for your time. I know you are so busy these days, but thank you very much.
It's okay. It was really a pleasure.
Dr. Tamer, you are so calm and sure of your information, and I always enjoy any scientific activity with you. Thank you very much.
Thank you. Pleasure.
Bye. Bye.
Bye.
Bye.